Hi, everyone.
Hi, Dr.
It's 6. I think we give a minute or so. We get a few more participants. Then we should be able to start off.
All right, so
Okay, I think we can start. Good evening, everyone, once again.
good evening.
My name is Dr. Nganga, and I'll be facilitating today's CME. We are very privileged to have an interesting presentation by one of our senior colleagues. So I would like to take this opportunity to welcome you all, and also to welcome our partners, Troikaa. who will have an opportunity to us later. So before we go to the main presentation, I would like to invite Dr. Caroline Mwangi to spend a few minutes and give us a short case presentation that is in line with this topic. This topic is the quality of perception of anesthesia, but from a patient's perspective. So Dr. Caroline Mwangi, karibu.
Thank you, Dr. Nganga, for that kind introduction. Let me try share my screen. So I will request, in case you cannot hear me because I might miss the alert on the chat box, Dr. Nganga, please feel free to interrupt me. So as Dr. Nganga has put it, I'll be doing a short presentation on a case report, and this is more of a preface. Could I request we mute our mics, please?
Shelmy, maybe you can assist us with muting other mics.
Thank you for that. So Dr. Nganga, in case there's an alert that people cannot hear me, please do alert me. So this short presentation is just a preface to the gist of the talk, which will be done by Dr. Gathuya. And since today we are talking about quality, I decided to look around what quality of a healthcare service means. And what I found was one distinct definition by the Institute of Medicine. And they basically have divided quality into 6 domains, main domains. One, the service should be effective. Basically, so the service should be effective. Basically, you should be able to provide the service based on scientific knowledge and up-to-date knowledge. Number 2, it should be equitable, which means it should not be biased or based on patient characteristics or based on geographical location or socioeconomic status. So whatever quality of service you offer in whatever place, it should be standard and the same. It should be timely without delays. It should be efficient. It should be safe and patient-centered, such that you should be able to address all patient concerns as much as possible. And that Institute of Medicine goes ahead to applaud the anesthetic profession, because we are one of the few professions who put safety as one of the key objectives when providing the service. So in my searching around, I was looking for perhaps patient self-reports on an anesthetic service that they have received. And when I was searching, I was not looking for data that has been collected scientifically using questionnaires and then analyzed. I was looking for reviews and self-report. I could not get any. However, I came across the Medical Protection Society, and the one based in the UK mainly. And what they do, amongst other things, they represent healthcare professionals in many things. So from disciplinary to inquiries to patient complaints. And in the year, is it 2017 or 16, they analyzed 3 cases that are regarding the anesthetic profession. And of these, 500 were related to patients complaining about one thing or another that had happened to them during the anesthetic. And the main things that they complained about were 1, dental injury, that really topped the list, attitude and the demeanor and rudeness of the healthcare or the anesthesia provider to the patient, inadequate post-op analgesia, painful or repeated attempts at cannulation, that seemed to also be a feature, inadequate sedation, lack of informed consent, especially for regional techniques, cancellation of unnecessary delays in surgery, and spinal and epidural also played a key role amongst the complaints. And regarding this one, it was ineffective, or there were certain complications, either patients developed post-dural puncture headache, developed an infection, or developed a neural damage, which they attributed to the neuroaxial anesthetic. And it's interesting because the other day in the anesthesia forum, there was a really huge debate and discussion regarding post-dural puncture headache and perhaps how we can protect ourselves from patients. So this case profile is to do with a 39-year-old female who had 3 living children. She had bilateral enlarged breast, and she required reduction mammoplasty because it was affecting her daily life. And she was also having back pain, neck pain, and her self-esteem and image. And she's also a marathoner, and she felt it was time that something needs to be done about it. She had had 3 previous surgeries. 1 was under GA and 2 were under spinal anesthetic. She generally physically fit lady. And on physical examination, there was nothing remarkable to report about her. So she had a few concerns. 1 was nausea. Why? Because in about 2 of the 3 surgeries, she developed severe nausea post-op. And also she usually has motion sickness on and off. And also in her daily life, there's sometimes she has nausea, though she couldn't specifically pinpoint what triggers the nausea in her daily life. The other concern she had was to do with pain control. So when I inquired further, on a scale of 1 to 10, her satisfaction with the pain control during her previous surgeries, she scored it a 5 to 7. So it was either moderately painful. That's what I got from her self-report. My concerns, or our concerns at the physician, was 1, her risk of postoperative nausea and vomiting is 60%, and this is based on the Coiburanta score. And then the other thing was, how are we going to deal with the pain? 1, because the duration of surgery was going to be long. We're doing bilateral reduction mammoplasty. And then there was going to be extensive tissue dissection and the manipulation. It was going to be on both sides of the thorax, and post-operatively, she would leave the operating table with a minimum of 2 drains. The other concern was bleeding. So we discussed a few things. 1, we told her we'd put her on multiple antiemetics given a 60% risk of developing nausea and vomiting post-op. And the other thing we did was discuss pain options. And this was a tough one because we tried to think through everything that we could. Were we going to give single shot, regional techniques on both sides of the chest? But single shot meant her pain was just controlled for a few hours, and then would have to use a multitude of drugs to control the pain post-op. So we decided that we're going to use an epidural, a thoracic epidural, a continuous infusion for that matter, and combine this with either parenteral or enteral analgesics, and as much as possible, avoid opioids. But in case she was going to have breakthrough pain or not happy with the pain management, we're going to add on an opioid. So the other thing we did is, of course, prepare some blood and blood products preoperatively, and also took the time to discuss with her about the difficulties or differences between a thoracic epidural versus what she had received, which was a single shot neuroaxial blockade, which she said was okay. So here, I'm not sure whether we jinxed ourselves because intra-op, it was very interesting. So on the day of surgery, I actually borrowed or got a PCA pump from one of our colleagues. Thank you for that. I couldn't get it before. So you can imagine I had to educate the patient on the PCA pump that morning of surgery. So I really prayed she got it, despite being a little bit anxious about the operation on the morning of surgery. The other thing that happened, for some reason, the day I needed this thoracic epidural to work the best, it's the day it was so challenging. Funnily enough, I had requested a colleague to join me. I have no idea why. I just insisted, just come, we do this. And now I understood why, because when we were about to give up, at the last try, it got in and was so happy. Luckily, because we had reassured the patient throughout and we had talked about this preoperatively, she was more okay and she was willing. She was just like, you keep trying, I know it will benefit. So intraoperatively, we combined the general anesthetic with an epidural continuous infusion. We used bupivacaine 1% with a combination of fentanyl 2 mg per ml. Post-operatively, when she woke up, I had a concern because given the technical difficulty we had experienced instituting that epidural, I had to wait for her to completely wake up to assess her sensory and motor blockade in all her limbs and to ensure that nothing had happened or there was no form of acute injury into her spine or anything. Luckily, there wasn't. So post-operatively, we continued with the epidural PCA infusion. Within 6 hours, I saw her again because I happened to be around and she was sitting in bed very comfortably. And by evening, she had something to take and she was very comfortable. The following day, when I came to check on her, she was actually sitting out of bed with her drains and the PCA pump. And I think overnight, she had given 2 boluses of the medication. We managed to maintain the epidural in situ for 4 days. And this was good because during the change of dressing, she was able to give a bolus a few minutes before the surgeon changed and she was very comfortable. This patient was discharged home on day 5. She was happy one. At least we had managed to manage her pain beyond her expectation. And secondly, she was able to move. In fact, where she was saying all the people were asking her why she's able to walk around so early, yet she's from theater. So my learning point from this one, given the technical difficulty, and we were working in a theater that is not used, it's used to more of single shot neuroaxial blocks as opposed to thoracic epidural. The whole team kept wondering why this thoracic spinal, as they called it, is taking forever. But thank God the patient was calm because we had explained to her. So that went a long way in also calming us and helping us to try. And then because a PCA pump use is also not common, it involved a lot of footwork, a lot of work, a lot of educating the staff. The nurses in the ward were more afraid of the pump because some thought it's something that is going to the heart. They couldn't understand what it is. So I had to be really and get also some students to work with so that we could make it a seamless experience for everybody. And at the end of the day, we had a happy patient and the whole team was happy. Thank you.
Thanks a lot, Dr. Carol Mwangi, for that precise and detailed case presentation. Now, at this point, I will go straight into inviting our main presenter. Our presenter for today is Dr. Gathuya. Dr. Gathuya has been a teacher to most of us, and she is still practicing anesthesia, but also has developed a lot of interest in public health. So, Dr. Gathuya, please, karibu.
Thank you, Dr. Nganga. I will try and share my screen. Okay, so what is that thing for? Can you see my screen? Dr. Nganga, can you see my screen?
Yes, I can see your screen.
Okay, perfect. So today we are talking about perception of quality of anesthesia from patient's perspective. And we'll go through a few things. Some of the things that I'm going to say actually tie in very nicely with what Dr. Carol has said. So perception, I just thought maybe we'll go through what is the definition of perception. And it's actually a belief or an opinion that is held by many people of how things seem. So it is not something tangible or objective. And we'll see how this affects how we deal with perception of quality. So perception, you have interactions of experiences and expectations. So if a patient has low expectations, then they are easy to satisfy. If a patient has high expectations, then they are easy to disappoint. So you really have to worry. It is not an marker of the quality of what you're doing. So when we look at expectations, what are the things that form our expectations? And sometimes it's the reputation of the entity, either the institution or provider. This is why you hear some people say, with all due respect, that if you're in a high-ed hospital, you expect high-ed quality of care. Or if you are in another low-ed institution, then you probably don't expect much. We also hear about provider reputation. So you'll hear people saying, if you're seeing Dr. So-and-so, then everything will be fine. As opposed to they say a name and you're like, who is that? I've never heard of them. Are you sure they're good? So those are the things that fuel expectations. So the other thing is about the nature and seriousness of illness. For most people who are very sick, then they're not so expectant about many things. They don't worry about, they basically are keen to be treated for what has brought them to hospital. As opposed to somebody who is coming for some elective surgery that really doesn't have to be done. They tend to be a bit on edge. They expect so much. They have what they're expecting out of the outcome, especially for cosmetic surgeries and the like. The other thing that fuels expectations is the choices available. So if you have a lot of choices, then of course your expectation will be high, as opposed to somebody who doesn't have a lot of choices. So the other thing that fuels us is our expectation is what are your previous experiences? And this is what Carol has talked about extensively, that the patient's previous experience of postoperative nausea or pain management may make them expect the same or expect that you will do better in this anesthetic. What are the social and cultural norms? Sometimes you find, especially for a procedure like circumcision, the ritual circumcision, and the boys are told you're not supposed to say you're in pain. So even if the patient is in pain, they expect the pain. Or the way we are socialized about childbirth, most people think that it is okay to be in pain when you're giving birth, which we know it is not true, but that is a social cultural norm. So for some people, if they expect that childbirth is painful, even when they're in pain, that's what they expected. Others may come from another socialization where they know you're not supposed to feel any pain. So if they come to a place where the socio-culturalization is different, then they will think that it was very painful. The other thing is about the patient attitude. And this affects how they view what you're telling them. The demographics, whether they are male or female, whether they're children, adolescents, all those things affect what they expect. And of course, knowledge base. People who are more knowledgeable sometimes can expect a lot or can be more realistic about their expectations. When we talk about patient satisfaction in healthcare, because it is not something that is straightforward, we have to think about theories of this. And some of the things that we look about, most of these theories were developed in the 1980s when there were a lot of motivation to do what is patient satisfaction. So the first theory that was described was discrepancy and transgression by Discrepancy and Transgression Theory of Fox and Storms of 1980, and Expectancy Value Theory of Linder Pels. And this is the one we mainly use. This is what they expect versus what they receive as their value. And that has extensively been studied and upgraded. If you're interested, we can have that discussion later. The other one is Determinants and Components Theory of Ware et al. Of 1983. And this is about what you expect. If you have the healthcare provider and you have the patient, at what level do they meet? So if their determinants and components come together, then they are satisfied people. If they are off a bit, then you have unsatisfaction. And then you have the multiple model theory of Fitzpatrick and Hopkins of 1983, which has also its main use, especially in specific cases like maternal health care satisfaction. And then there's the health quality theory of 1980. So when you go into all these theories, it helps explain how these patients value satisfaction. So why does perception matter? And one of the things is that it is inherently meaningful, and it's a powerful driver of outcomes to other stakeholders. For example, we have stakeholders being our patients, the surgeons, the hospitals. So if the patient perception thinks that you are a bad doctor, or if the surgeon thinks that you are a bad doctor, has a perception, then they will not call you for cases. So you find that the same perception helps with choice of doctors. I'm sure we have all seen where, especially where patients have choices, where they get told, oh, so-and-so is going to give you anesthesia, and they say, no, not that one, get me another one. Or they're told, oh, so-and-so is going to be your surgeon or your obs-gyn, and they say no, because of the perception that they had. You've also seen patients who, or even ourselves, you go to a doctor, you're seen, and you're so unconvinced about what they tell you that even if they gave you medication, you will not take it. You just throw it away, or you go for a second opinion, or whatever instructions they give you, then you're not able to follow. The other thing that is very important, especially in our setup, is litigation. And it has been shown that patients who had a perception of satisfaction, had a perception that they were well taken care of, had a perception that they had high quality care or service, have a lower tendency to litigation, even when things go bad, because they feel you tried. On the other hand, if their perception was that you were not paying attention or you were not kind or anything, then the tendency to litigate, and Carol actually referred to this, is actually very high. So you find that, like in that medical protection society, it gives you a high level of patients' complaints, and that complaints come from unmet expectations or perception of having not been given quality care. So what is quality of anesthesia? So we say that quality of anesthesia per se is abstract and elusive to construct because it is intangible, it is heterogeneous because there are so many factors that play into that quality, and it's difficult to separate production from consumption. So when you have everything tied up, how do you move? How do you tell that this was an intra-op issue or pre-op issue or post-op issue? How do you tell that they feel it wasn't quality because of the expectations they had? So it becomes very elusive to construct the quality of anesthesia. If I give you an example of, if you think about how we evaluate, let's say like spinal needles. So people who will go for TECs, or you'll find many on the anesthesia group, people will say, who has used this spinal needle or this drug? then people have things to say, or about the length, about the shortness, the sharpness, about how it bends easily, or ETT, how hard it is, how soft it is, how accurate it is. And when you're assessing the quality of an object, then you can have an objective evaluation as opposed to evaluating the quality of a service. So, and this one, I'll not spend much time with it because Carol already mentioned this from the Institute of Medicine and the 6 domains of quality. It has to be safe, effective, patient-centered, timely, efficient, and equitable. And Carol already went through what those things mean. So when we think about quality of anesthesia or quality of healthcare, then we have to think about these things, because then that way we are able to say what kind of care we are giving. So when we define quality of anesthesia, we can say it is satisfaction with the anesthesia care given, where satisfaction is a perception of fulfillment of expectation and desires. So again, remember, we have talked a lot about perception. So the satisfaction and perception are quietly related. And remember, because of the expectations that we outlined above, this may give patient biases as to what they perceive as quality. Also, I want us to remember that satisfaction does not necessarily mean superior service, but acceptable and adequate service. Remember, we said that if a patient had very low expectations, then they will feel satisfied with something that somebody else would call mediocre. And if somebody had very high expectation, even what you may deem as very good quality care may not impress them. So it's a very relative measure that we have to think about. So I looked at what patients define as quality of anesthesia. And this is important for us to think about, because there are things that we can talk about. And number one on the list is attention and gentleness, which gives us patient-centeredness. So patients want to feel like they're part of their care management. They want to feel that they're being consulted, their views are being taken into account. If they're talking about their previous experiences, they're telling you about their concerns, they want to feel that you are listening to them. The other thing is about the technical skills and efficiency, and these include pain management. Pain management actually comes up very high in a lot of these quality issues. IV access. You remember the other day in the group, we had that discussion about IV access in Gertrude's versus the other places. Again, it's about perception and what has been done. Postoperative nausea and vomiting is another thing that people consider as a technical skill and efficiency for quality. And Dr. Carol mentioned that their patient actually had an issue about postoperative nausea and vomiting. And the other thing is awareness during anesthesia. So those are things that patients don't want to get into. The other thing is about communication and information sharing. And this is very key, because sometimes you can get a lot of misunderstanding because people are not, they don't feel like you shared enough information. And when you share information and communicate clearly and adequately, then you instill confidence in the patient or their relatives that you actually know what you're doing. And they feel that they can trust you with themselves or their kin. Sometimes we are called as anesthesia providers to be courteous and give emotional support. Not sometimes, all the time. We have patients who are going back to theater many times. We have patients who have had bad experiences. We've seen them, people with a lot of emotional issues. They want to feel that their concerns have been addressed. If the patients, like today I had a patient who was very unhappy from a previous experience, and she said that she was trying to express herself to the previous caregivers, and they told her, that's not a problem. We've been doing this for a long time, and it will be okay. And it actually ended up not being okay, and her baby had to be resuscitated. And she was not happy, obviously. So she felt that her concerns were dismissed. So those are some of the things that will define for you quality. The other one is the efficiency of care and organization of systems. Remember, especially I do a lot of pediatric anesthesia. So if you keep a child starved the whole day, of course, the parents will not be happy. But if you have a disorganized system that you don't even know who is coming next, who is going first, theater is running late, nobody
Serious.
is. Pardon? Nganga, what's that for me?
No, Doc, carry on.
Okay. So say efficiency of care and organization of systems. You really need to be sure that the system you have is actually well organized so that people can feel I'm scheduled for theater at 10 o'clock and I went to theater at 10 o'clock and everything was on time. Or the system, I was scheduled for theater at 10 o'clock. I had my bloods taken at 7. There are no results yet, so now I can't go to theater. So there are many things that interplay, and this is why we said it is heterogeneous, because you have to organize about the lab and the like. Or patient has been scheduled for theater day after day after day after day, and at the end of the day, nobody even goes to tell them why they didn't go to theater today. So all those things are different. The other thing that defines quality, especially, and this is especially important, I think in private hospitals, but I suppose even in other hospitals, if you go to a hospital and you have a very nice room and you have a perception about that room, then they are taking you to theater, the trolley is creaky, you're covered with a torn blanket, you're passing a lot of equipment on the corridor, it already gives you a perception that, hey, are they really able to do what they say they can do? Or if like what was said in the media the other day, where you go into theater and at receiving area, there's a snake. I mean, those things make you feel about the quality of anesthesia that you're going to get. So what are the factors that influence quality of anesthesia? So one of the things is good clinical practice. And this includes all the things we have talked about. Your technical know-how, how to communicate with patients, how to allay anxiety, how to take informed consent. All those things put together form good clinical practice. And the other one is sound organization. How does the system in the place where we are giving this anesthesia work? And one of the high things on this is it timely? Remember, we had markers of quality of care. One of the things that really comes up there is it timely? So if I'm going to theater at 10, do I really get to theater at 10? What are the other systems? Does the lab communicate with the ward or with theater? Do we have x-rays or other scans that are needed in theater from x-ray department already in the ward? So when you have all these things that form the structures and systems of the healthcare, then they help influence the quality of anesthesia, either positively or negatively. So why is it important to us as providers what patients feel about the care that we give them? Number one, it's good to continually improve care. So if we listen to them and hear what they say about our care, then we can improve our care. And the other thing is great for marketing. So if people say, so-and-so is very good with anesthesia for children, then people will know and they'll keep calling you, especially for those of us in private practice. For hospitals as well, they say, like now, that patient Carol had, if they know somebody who needs surgery, they will probably say, hey, I went to this hospital. Of course, the doctors may be different, but they will say, I went to this hospital and this was done. It was very good. I was happy. So happy patients market us. And as institutions, they improve return on investment. And if you look at where the beginning of all these studies on quality of anesthesia and patient perception in the West, where sometimes even the insurance companies pay a percentage depending on the quality of care you give. And for most of them, that quality is mainly the patient satisfaction. So you find that you get either 3% above what you had ordered if you're continually being rated as high quality or patients are satisfied. Where they do group practice, then people know if you go to that group, then you will get good care. So other people keep referring patients to you. And your hospital and your system is actually happy when your patients are satisfied. So how should we measure? Remember, you cannot improve what you don't measure. So we have said in the previous slide that we are measuring we want to use this information to continually improve care. So we cannot improve what we don't measure. So I was looking around at some of the things that people have measured, and this is a very elaborate paper, and I would be happy if most of us actually read it extensively, because I will just highlight what their main things were. And they were developing a questionnaire to validate the quality of anesthesia from a patient's perspective. And the top 3 things that featured from all the patients that they interviewed in this order was postoperative nausea and vomiting, how well their pain was managed, and communication and information sharing. Not to say that all those other things we have talked about are not important, but these are consistently high to show that this is what is important for most people when they think about measuring quality of anesthesia. So I also looked at our region. There is no article from Kenya, unfortunately. So the likes of the people in the universities, the challenge is up to you, because you are the ones who are going to do the studies and publish. I think it is important. So I found 2 articles from our region. One is from Eritrea and the other one is from Ethiopia. And these have almost the same setup with us. They are low-income country like us. And the conclusion was, in Eritrea, there was moderate patient satisfaction, but of concern, what came up with the perioperative anesthesia care was that there was low levels of information sharing. And even in our setup, if you talk to most people most people don't even know what anesthesia does because we probably don't spend as much time explaining what we do to the patients. And the other one was in Ethiopia, and the same conclusion, that there was low patient satisfaction, this one, and the main thing was about information sharing. So there is also another very good article that you can look at about patient satisfaction measures in anesthesia, and there are very many tools. Usually we say when you have a measure that has very many tools is because people cannot agree on exactly what is important. So everybody comes up with their own tool that captures some things that are important, and the next person comes up with something that is important. But why I put this slide here is to show you that there are actually very many tools that are available to measure patient satisfaction. And I think it is high time we chose a few of these and went to the ground and actually found out. Because I think it is good for all of us to know how satisfied are the patients we take care of with the care that we give them. This way will help us improve the care that we give. And once we know, then we enter into this, what is called the quality improvement cycle. And this is in almost everything. So you're seeking to improvement by feedback and other changes. So you do a study, you find out what do the patients say that are important to them in terms of quality of anesthesia given. You look at the results, and then you set a standard, and then you monitor and see whether what you have set has actually improved the outcome on the other end. So this is a continuous process. So you keep raising the bar as you continue. And in conclusion, just before I get to the end, what are we looking at in the future? I think we need to take more interest in the quality of care and the patient satisfaction. And from our setup, especially what we have seen from Eritrea and Ethiopia, and anecdotal evidence that we have, we really need to put more emphasis on effective communication skills with role playing and possibly simulation. Let's teach our younger colleagues, and even those of us who have been here now for a while, how to communicate in a simulated way under different circumstances, and then we can improve generally, and people can understand what we do. And the other thing is that we need to understand how patients perceive our care. We need to improve the patients and general public knowledge base of what anesthesia is, what anesthesia providers do. And I feel this is a major role that we can do as anesthesia providers, especially through the KSA. And also to realize that once we do this, it makes everybody more knowledgeable. It helps tame expectations. It helps people with no expectations to actually have an expectation that they can hold us accountable to. And also the other thing is to improve our technical skills and how we actually perform our anesthetic care. And this is something that KSA has put a lot of emphasis on. We have workshops for regional anesthesia. We have ultrasounds. We are talking about IV access. We are talking about postoperative nausea and vomiting. The things that we have seen actually make patients feel like they have been well taken care of. And I think we need to do studies in our setup so that we can know where we are and then we can set bars about where we want to go. And I have finished. It's time for questions.
Then,
Dr. Nganga, I have finished.
all right, thank you for the detailed presentation. That was very clear. At this point, I think we will invite Mr. Nchagwa from Troikaa to give us a short presentation from them as our partners, and then we'll handle the Q&A after at the end. Thank you.
Yeah, thank you so much.
I'm not listening even to it now.
No, there's something. Yeah, thank you so much, Dr. Nganga, and also Dr. Zipporah and Caroline for the presentation. My name is Edward from Troikaa Pharmaceuticals. So Troikaa Pharmaceutical basically is an Indian-based company that deals with anesthesia and pain management. When it comes to anesthesia, we have a full range of anesthesia products. So maybe just to highlight a few, we have bubitrol heavy and bubitrol plain. This is bupivacaine with dextrose and plain. So in case you need any of the sort, Troikaa has the two range of bupivacaine plain. We also have ketamine injection by the brand name Ketamax. And we also have midazolam. In midazolam, our brand name is Benzosed. We have both the strength, the 15 mg, the ampule, and also the 5 mg, which comes in a vial. We also have isoflurane by the brand name Isotroy, that is 250 mg for inhalation anesthesia. And we have Sevotroy, 250 mg. And this Sevotroy comes with a filler which you fix. So in case you have the vaporizer, and we will always provide that filler. Basically, we also have trofentyl, which is fentanyl injection, but very soon we'll be launching trofentyl or TFC. This will be the first fentanyl lozenges. It's a very unique technology. Probably in 2 months' time, we'll be launching fentanyl lozenges. But we also have Troipofol by the brand name Troipofol, that is propofol injection. This comes with a vial as opposed to the ampule, so it's easy for use because sometimes with the ampules, there's some few limitation in terms of breaking the ampule, in terms of contamination, spillage. So ours comes in a 20 ml vial. The brand name is Troipofol. And now, as Troikaa, we have one Diclofenac injection by the brand name Dynapa EQ. This is 75 mg Diclofenac injection in 1 ml. And this is very unique. This is our very unique patented Diclofenac injection. As the brand name Dynapa EQ, EQ stands for Aquatech. So Dynapa injection is manufactured by a technology called Aquatech, and therefore the name Dynapa EQ. So Diclofenac injection is one of the oldest molecules in terms of pain management. And we have the conventional, what we call the old Diclofenac injection, which comes in 3 ml. And this is the first Diclofenac injection, including the innovator brand, having invented 3 ml Diclofenac injection. This Diclofenac injection, conventional 3 ml, was basically invented to help in pain. But at the end of it, it has its own limitation. And some of the limitation of Diclofenac injection is the available current Diclofenac injection, the conventional one, is 75 mg in 3 ml. So this 3 ml formulation contains propylene glycol as a solubilizer. So this actually makes it difficult because sometimes there are a lot of limitation when you're giving intramuscular route. There is a lot of pain at the site of injection. So because of the large volume of administration, it stretches and distends the muscle fiber, leading to muscle damage and therefore pain. This propylene glycol in this old diclofenac injection produces pain and hemolysis at the site of injection. And because it's 3 ml, the route of administration is very limited. You cannot give, even if you're choosing as intramuscular, you cannot give intradeltoid because the volume is very high. Because you realize that intragluteal routes poses difficult in post-operative or operative and also in bedridden patients, and most for the anesthetist. You realize that most of the patients are either bedridden or they are anesthetized. So during that time, going for gluteal injection in using this old diclofenac injection becomes a big challenge. Another challenge is the viability is compromised in obese patients, because in obese patients, while injecting, sometimes you realize that the injection does not reach at the site where it is intended. So it's a very challenging, and therefore bioavailability of the drug is very limited. Again, just like I said, that the efficacy, because of the thick fat muscles of the intragluteal injection, mostly in obese patients, this old diclofenac, conventional diclofenac 3 ml becomes a big challenge. And also, there is high osmolarity due to this propylene glycol because it's oil in nature, and therefore there is high osmolarity. And this has caused a very big difficult, and it leads to phlebitis. So as we see that it is really, even some of the studies, one of the studies that was done to determine whether IM injection when given intragluteal reaches the intragluteal muscle. The study clearly shows that 32% of the patients, drug did not reach the gluteal muscles. And 68% of the patient, it was found that the drug was deposited in the subcutaneous fat. And therefore, the conclusion is the majority of assumed IM injection may actually be subcutaneous, hence result into delayed onset of action. Because the main aim of giving a diclofenac injection is to relieve pain as fast as possible. But if there is delayed onset of action, and therefore this does not meet the objective of giving the injection. Again, the same, if you look at the needle, the 35 mm needle and the 25, another study clearly concluded that it did not reach the gluteal muscle in considerable number of patients, and instead the drug is administered at the deposited in the subcutaneous tissues. So this clearly shows that even if you are choosing intragluteal muscle with 3 ml diclofenac injection, the drug does not really reach the gluteal muscle. So there is a lot of limitation, even when you're giving intravenous. If you're giving diclofenac 3 ml intravenous injection, the limitations are there. It can only be administered as slow IV infusion. So this conventional 3 ml injection, diclofenac, can be only administered as slow IV infusion. There is slow onset of analgesia effect. And sometimes while giving this 3 ml diclofenac injection, you need to buffer with agent like sodium bicarbonate to adjust the pH. And therefore, it's a complex process. And also, the high risk of thrombophlebitis and pain at the site of injection with propylene glycol. This is all with 3 ml diclofenac. So as Troikaa, we thought this is a good invention of diclofenac injection. But what can we do to better this diclofenac injection for patient compliance and also for the doctor who are using it to ensure that their patient receive the best medicine that relieves the pain? As a company, we are into innovation. So for the first time, we reinvented diclofenac. And we are the first company and the only company with diclofenac injection as 75 mg in 1 ml. In the market, there are 3 ml, 2 ml. But we are the only company with 1 ml, 75 mg, the same strength. And this time, we are not using propylene glycol, but we are using water as a solubilizer, and hence the name Dynapa AQ. So Dynapa injection is a very unique Diclofenac injection. It's manufactured by Aquatech process, and this is patented not only in few countries, but in more than nine countries, including in US, in European, and also in Canada. So compared to other form of Diclofenac injection, this is free of propylene glycol. Dynapa injection is free of propylene glycol, and therefore it makes it less painful while injecting. And therefore there is significantly less phlebitis. Again, because Dynapa injection is 75 mg in 1 ml, this gives you an option as an anesthetist. Also, you can choose to give it as intradeltoid. And therefore, this is convenient. You realize that also in most settings, giving in OPD patients, giving even in intradeltoid is more convenient. And if you choose intramuscular, and that is strictly intragluteal as opposed to intradeltoid, you realize that bioavailability of the drug is very fast when you are using deltoid. So this is the only Diclofenac injection, Dynapa, which can be given as intradeltoid. One of the breakthrough with Dynapa injection that it can be administered as IV bolus. And we all understand that IV bolus, there is faster onset of analgesia, which is your main objective, and I believe is that to relieve pain as fast as possible. So with Dynapa injection giving as IV bolus, there is faster onset of analgesia. And this gives you as an anesthetist an advantage in pre and post-operative pain. Instead of using something like tramadol, which has some side effects like nausea and the rest, at least you have Dynapa injection, which is the only Diclofenac approved as IV bolus. So you can choose injection. All of these claims are not just claims, but they are supported by published clinical studies, and we have all the studies in international journal. When you mainly compare Dynapa injection, which is 75 mg in 1 ml, and the conventional Diclofenac 75 mg in 3 ml, there is a very big difference. As I earlier highlighted, there is an Aquatech process in this. And therefore, with Aquatech process, this is free of propylene glycol, Dynapa. But when you compare Diclofenac 75 mg, it has propylene glycol, which causes a lot of pain and phlebitis. Dynapa injection virtually painless at the site of injection, as compared to Diclofenac conventional, which it causes pain 2 to 3 hours post-administration. Dynapa injection also gives you an ability to choose any route of administration. You can choose intradeltoid, you can choose intragluteal, you can as well choose IV infusion, and also more importantly, IV bolus as a slow push. You look at the other Diclofenac, you can only give intragluteal, and if you choose IV, it can only be IV infusion, and that is after buffering. And you might have found some, sorry for that, I think someone. So you might find that in some of the companies, the Diclofenac injection is written as IV, but then when you read clearly, there is infusion down. So sometimes you might think that their Diclofenac injection is approved as IV bolus. No, it's IV infusion, and this should be after buffering. For Dynapa injection, you can give IV infusion without buffering, and also approved as IV bolus slow push. So another advantage is that there is uncompromised bioavailability in obese patients by deltoid route, as opposed to giving intragluteal in the other Diclofenac. In OPD setting, this is one of the best because you can choose intradeltoid. It saves you time. Also, this is very critical, but I don't know how it applies. Sometimes there is patient embarrassment when you're going for gluteal injection. So when you're going for 75 mg, you choose intragluteal. Some patients, mostly the female patient, might not, there's some sort of social embarrassment that is related to this. But with Dynapa injection, instead of going intragluteal, you can use as intradeltoid. And more critically, in IV bolus, there is faster onset of analgesia, less incidence of thrombophlebitis. There is no need of infusion line. hence the cost also is effective, because if you're going to have an infusion line, you're going to also use sodium bicarbonate. This is an extra cost because again, you have to use an extra syringe. But for DINAPA injection, there are no all those costs. So when you look at also cost, DINAPA injection tends to reduce the cost of treatment as total, as opposed to the other Diclofenac injection. So just a wind up, it is manufactured, DINAPA is manufactured, a brand of Troikaa Pharmaceutical with an Aquatech technology, faster onset of analgesia as opposed to conventional Diclofenac. It is free of propylene glycol, versatile route of administration, that is intradeltoid, intragluteal, IV infusion, IV bolus. And as I say, even IV infusion, there are less chances of thrombophlebitis. IV bolus, quick and superior pain relief. One of the, actually, this DINAPA injection is highlighted in one of the most referred book called Martindale by brand name. So that's something to show that it is a brand that is not only known here, but it's a worldwide brand. As I said, it is in 99 countries. Lastly, just as a just to remind you of other brands, as I say, kindly remember we have Bibitroi plain. You can always get it from Troikaa. Bibitroi heavy as Bibivacaine heavy. We have Ketamax, which is ketamine injection. Benzosed, which is midazolam. Isotroi, isoflurane, and Sevotroi. And we have Trophentine, and also we have propofol injection. So if you need all these brands, you can always contact Troikaa using the following contact. Our distributors, Harleys in Westlands. We are also in Kisumu, in Eldoret and Mombasa. That is the Harleys. You can always contact me. That's my mobile number if you need any kind of those sort of drug, or you can contact Aditya Rai, the numbers on the screen. So you can just jot down the numbers. If you need any drug, kindly contact us. Our prices are also friendly, and as well as the quality is very high. So thank you so much for the time allocated to me. Thank you so much, Dr. Nana, and all the participants.
Thank you, Mr. Edward, for that presentation on products that at least most of which we use on a day-to-day basis in our practice of anesthesia and critical care. Thank you also for the opportunity to partner with us in today's CME. At this point, we'll go to the Q&A. Dr. Kochi, and this goes to Dr. Gathuya. Dr. Gathuya, you're still with us?
Yes, I am.
Dr. asking, what is meant about disclosures when an event occurs, either
Okay, one of the things,
either an explanation or an apology?
okay, one of the things that I talked about is communication and information sharing. When you're taking your informed consent, there are things you have disclosed, you have talked about that could go wrong. And if those things go wrong, then it becomes easier for you to go and tell them, we had talked about this and it has actually happened, and this is what we have done in retrospect, to take care of the patient. For example, if you're going to fix a central line and you've told them that there's a possibility that you can get a pneumothorax, and you go ahead and get a pneumothorax, then it becomes very easy to go and tell them that we actually got a pneumothorax, but like we had told you, we have fixed in a chest tube, it's going to be there for a while. It becomes more easy to deal with a complication that you had already mentioned preoperatively. for a complication that you had not anticipated or you had not talked about, again, when you're taking your consent, you're talking to them, you're able to gauge the level of engagement of the patient or their relatives. So you know, this one I expect trouble. It's always good to go with somebody else. What has been advised is that you just go and state the facts, if that is possible, because some of these things that you say at that time are the things that will be used as follow-up should they even decide to go to litigation. And remember, we say that if patient feels that they were more satisfied with the whole process of care, even when you have bad outcomes, then the level of litigation is low. If you talk to the lawyers, and I'm not a lawyer myself, they will tell you, do not apologize. Because most of the time, because you don't know what is going through their mind. When you apologize and say, I'm sorry, I gave an overdose, or I'm sorry, they take it as an admission of guilt. So you're better off just stating the facts that we gave this medicine and it did not do what we expected, and now we have a bad outcome. But do not say, I am sorry, I did ABC. I don't know whether that makes sense, because when you apologize, if this patient ends up litigating, then it becomes like an admission of guilt. However, it is important to seem to empathize. Remember, we said about emotional support. You are having to go out of your way to support them emotionally. If you're not able to do that, have somebody you can do this, who can do this. So when things go bad, especially when a patient dies or a patient now has to go to ICU, when you talk to the relatives, it's always good to have a third party, somebody who can, because if in the event they now decide that they are not happy with the care or they want litigation, or other people come later and tell them, maybe you should have asked this and that, then your third party, the witness, becomes a witness of actually how the conversation went. So be empathetic, tell the facts as they are, but don't apologize, because that is an admission of guilt. I don't know, Kochi, whether that answers your question.
Yes, it does. Thank you very much, Dr.
Okay, still on the same line, Elizabeth Igaga is asking, how much information is too much, especially regarding rare complications that can occur in a procedure?
Okay, so what happens is that in the issue of you're taking an informed consent and you're sharing information, you want to make the patient knowledgeable enough without scaring them. I've had surgeons say that the patient refused surgery because the anesthetist went and scared them off. So you want to share enough information for the patient to make an informed decision without scaring them. However, there are patients who ask you direct questions. When you ask a direct question, then you have to answer truthfully and correctly. I've had an incident where a 12-year-old asked me, have you ever put somebody to sleep and they didn't wake up? Of course, because we know that anesthesia, there is that possibility. When that question has been asked, then you must answer it truthfully and also take the chance to reassure them that this can happen, but in this setup, this is the possibility of such an occurrence happening. But don't tell them no, that won't happen. So how much is too much? So it depends on how much the patient know. When you engage them with talking, some of them lead you into very deep discussions about very, very nitty-gritty things that they have Googled. So sometimes, depending on the rapport you've created, you can ask the patients, so what did Dr. Google tell you? Then you can start your discussion from there. Then you know they have read about all the very rare occurrences. And if they bring up a particular very rare complication, you tell them. In medicine, we do statistics. So the chances of that happening is maybe 1 in 10,000. But if that 1 in 10,000 is your child or is you, then for you it's 100%. So that they know that you're not trying to run away from what can actually happen, because if it happens, and be very careful. If patients ask you about a specific complication, please write it down in your notes that you talked about that complication, just in case that same complication happens. Elizabeth, is that okay? Elizabeth?
She seems. All right. Any other question? I'm not seeing any other question on the chat. I'm not seeing any other raised hand. Any other question from the members? All right. I'm not getting another question. So at this point, I would like to thank everyone who has participated in making this CME possible and a success. Dr. Gathuya for your very detailed presentation. Dr. Mwangi for the case presentation. KSA for hosting us and bringing us together. And then our partners, Troikaa, to Edward Mchagwa for your presentation and for partnering with KSA. And all the participants, both in Kenya and from our neighboring countries, Ethiopia, Tanzania, Uganda. Thanks all for taking your time to come and be in this CME. I think this brings us to the end of the presentation. Thank everyone and have a good evening. Let's meet next Thursday for the next week's CME.
Thank you, Dr. Nganga.
Thank you.